Good morning. Good morning. I know, what an enthusiastic group of people. You know, it's so much fun, actually, starting off a celebration such as this. And this is an incredible celebration we're participating in today with so much enthusiasm in the crowd. You've been to gatherings where people are sitting in the crowd and everybody just staring ahead, waiting for something to unfold. Here, just by the discussion in this room, just by the vivacious communication channels that are going on in this room, we know that we're all set for a very special event today. So this is part of a 10th anniversary birthday bash. Right? This is not just the School of Public Health celebrating this 10th anniversary, but it's here. It's the Herschel S. Horowitz Center for Health Literacy that, oddly enough, is also 10 years old. And certainly to the benefactors of the Horowitz Center, this is a great time to remember the influence that Captain Herschel S. Horowitz, U.S. Public Health Service, played on public health, his influence, the influence of Alice in continuing that work here at the school. We begin with that reflection backwards. We begin with discussing the topic of health literacy and its important inputs and its important role in what we do in public health. It's my pleasure today to welcome two guests, and we're going to have a talk show format first. So Christine Prue from the CDC is here, and Dr. Rima Rudd from Harvard is here to help us kick off and have discussions on this important theme. So as the current dean of the School of Public Health, the person who's here as part of a team leading us into the next 10 years, it's my pleasure to kick off this session. But we also look back, much like we mentioned Herschel, much like we talk about our past, what's gotten us here. Ladies and gentlemen, I'd like to introduce the founding dean of the School of Public Health here at the University of Maryland. Give it up for Dr. Robert Gold.
Thank you.
You're welcome.
I'll ask first that you forgive the informality of my dress. It is very difficult to put sport coats over a compression wrap like that, and it's very difficult to button buttons. So I am dressed as best I can. But I'd like to share with you a story about how we began a journey in 2005. In 2005, I wrote a proposal to the University of Maryland and to the state legislature to create a School of Public Health at the University of Maryland. And it took us a while to get permission from the state of Maryland and everyone on board here at the university. But when we did, we had a launch date set. That launch date was September 27th, 2007. That was the start, the first official day of the School of Public Health. And we had a big event out in the back of the building, in the overhang in the back and the parking lot, and we had a couple of hundred people out there and some dignitaries from around the state and the nation. It was really very nice. But about a year before that actual launch happened, Dr. Moat, who was then the president of the University of Maryland, said, "You have to have a signature event to announce at that opening, in addition to just simply the creation of the school." Now, when I wrote that original proposal, I did an analysis of all the top 10 schools of public health, and I found that every one of them had at least two centers that were common to every one of the top 10, in fact, every one of the top 20 schools of public health. One was a prevention research center, and one was a center for minority health. And I'm using that word explicitly because I said that if we're going to be a top 10 school at some day, we have to at least have those two entities. But it was Alice Horowitz, who I first met in 1980-something, who really had the spark of an idea. Now, I always believed that one of the best predictors, if not the best predictor of the health status of populations anywhere globally, is the literacy and health literacy levels of the women of childbearing age in the population. I think that if you have a health literate group of women who are of childbearing age in a society, their children will be healthier as they grow up, because their first real caregiver will understand how to take advantage of information, how to utilize information, how to act on information appropriately, and how to find information. But Alice came to me with the idea of creating a center for health literacy. And what made it a signature event was that at that point in time, there was no other academic program in the nation, or in fact in the world, that actually had an endowed center for health literacy. So we were very proud on September 27th, 2007, to announce the Herschel S. Horowitz Center for Health Literacy, based largely on Alice's vision of what would happen and Alice's support for what would happen. Alice Horowitz, if you wouldn't mind, would you stand up, please, so that people who don't know you at least see who you are. I don't want to take any more time from the program, but that was the real signature event of that day, announcing the first academic center for health literacy in the nation. Thank you all very much.
Well, I want to thank our current and our former dean for setting up the conversation that we're now going to have with my beloved friend and colleague from CDC, Dr. Christine Prue. So Chris and I don't know if we even remember when we met exactly, but we've long time ago. When we were teenagers, yes. But what I thought we would do today is have a little bit of a discussion about Chris's career in particular and how it's evolved in public health communication, and broadly let you see how it is that health communication and health literacy really influence the practice of public health. So Chris has had a very long and illustrious career starting in local public health, which we're going to talk about. And I think you've been at CDC now 20 plus years.
20 years.
And her current position is as the Associate Director for Behavioral Science in the National Center for Emerging and Zoonotic Infectious Diseases, also known as NCEZID. But in the HHS Health Literacy Work Group that we ran, we were not allowed to use acronyms. So we always had to say the National Center for Emerging and Zoonotic Infectious Diseases.
And that determined whether you got through the door or not.
Exactly. That was the secret handshake.
Yes.
So Chris and I are going to talk. I've got a couple of questions that I'll start with. And if you all have questions, we'll turn to you at some point. And if you don't have any questions or comments at that point, we'll continue with the questions that we have. And then after we've talked for a bit, I'm going to introduce our other colleague, Dr. Rima Rudd from the Harvard School of Public Health. Rima was there on September 27th, 2007. And so in addition to that auspicious event, we also have a named fellowship after Dr. Rudd, and recognizing her signature contributions to the field as well. So that's what we'll conclude with. So Chris, let's begin with something you and I are firmly committed to, this notion of main messages. So what is your main message to our group here today about health communication, health literacy, and their connection to public health?
The main message, I would say, is that we cannot succeed in our mission of public health unless we address health communication and health literacy. We just can't. And we're failing a lot of communities because in pockets of even in the federal government and state governments, we're not taking health literacy and health communication seriously enough. We're not building it into the organizational cultures. We're not building it into the practices. And some of our organizations have cultures and processes that work against health literacy, whether it's in the medical domain or the public health domain. So we have a lot of fixing to do So I'm excited that your center's here to teach the next generation of students how to do it right, so that you can go into the organizations that you work in and be real change agents in applying the science of health communication and the practices of health literacy. Both have strong science bases and practice bases, and we have a lot of people who have bad habits when it comes to communication, and undoing it in a workplace like CDC, it's really hard.
Okay. Well, the follow-up question then will allow you to elaborate and give some examples of that. So I don't know how many people know, but you actually started your career in Maine, working in local public health. And I'm guessing that a lot of people here don't know the significance of Maine in the trajectory of the field of health literacy development. So could you explain a little bit about how you learned about health literacy and how it shaped your thinking as you've worked over these years in public health?
Sure. I was really fortunate to be early in my career leading health promotion programs for the city of Portland, Maine, which basically served all of southern Maine, because Maine does not have health departments in the counties. It's a very eclectic mix of public health functions. And Sue Stableford, it was Plimpton at the time, she's changed her name, recruited me to participate in some training workshops with Jane Root. If you don't know Jane Root, she's one of the co-authors of one of the seminal books around health literacy, which was Teaching Patients with Low Literacy Skills. And it was an amazing book. And she had retired to Maine, her and Gus. And she was not retired when I met her. She was going full steam. Really a talented visionary in the world of literacy who joined up with Sue Plimpton or Sue Stableford and others, and imagined what is the Maine Health Literacy Institute, which is 20 years old or older. They used to have wonderful sessions in June and July, which is a great time to be in Maine, to spend a week learning these skills. But I really learned from two of the best in the industry the skills I needed. I had great health education foundations. I'd gone to UMass Amherst, learned community health education, was working in a health department, doing all the things you know to do, engaging the community and identifying problems, and then engaging the community in solutions that would work in that community. And people don't know this, but Maine has a huge refugee population, and it was in my encounters with resettled refugees I realized that, oh my gosh, our materials, our forms, the way we're communicating with this entire group is not working. We did not have fluoride in our water back then, so kids were graduating with dentures as their high school graduation gift. So we had started this oral health program that gave children tablets and rinse in the schools, and none of the refugee kids were enrolling in the program. So it took some audience, basic good old know your audience, get out in the field, engage parents, understand kids, what are their drivers. This is where, for me, the connection between behavioral science and communication science is like this, because you want to understand what the drivers are and do it in a way that you can listen and learn from those populations and build interventions that work. But it was through that process that I realized I still had a lot to learn, and I was like a sponge with Sue Plimpton, or Sue Stableford, and Jane Root, who just sort of took me under their wings, taught me everything they knew. And it was under their mentorship that I ended up saying, okay, I need more, and I landed here to work on my doctorate degree. So it's a continuous process of learning, and surrounding yourself with people who are you're willing to learn from, and being at the right place at the right time, because you couldn't have picked two better mentors in this world, and just landing here to take it to the next level.
Well, and that's the next question. Your undergraduate degree is in biology, and then you went on to public health, specifically health education, and as you mentioned, you got your doctorate here from the Department of Health Education. Mm-hmm. So how do you think starting in biology has affected the way that you think about communication and health literacy? And if you could comment a little bit about how your training here specifically at UMD affected how your career has unfolded.
Okay. A lot to that question.
Okay.
Well, I actually was biology because I was going to go to med school. I had planned on being a medical missionary save the world, one person at a time. And I love science, and I still to this day, I'm in the center I am at CDC because I'm surrounded by brilliant microbiologists and epidemiologists and virologists, and I love science, so love learning. And every new day there's something new to learn. But I went overseas for one of the summer experiences I had, and it was in Nigeria, West Africa, and I had a moment over there where I realized all these diseases are preventable. What is the issue here? And I had this moment, epiphany moment, where I said, I don't want to be on the diagnosis and treatment side of things. I want to be on the side of prevention. So I came back, went to my local librarian and said, what career does prevention? Because I didn't never heard of public health, and that led me to that and led me to get on my public health degree. But I think, my love of science, a love of applied sciences, and health is an applied science, and my passion for prevention sort of has led me to this place where I see health behavior and health communication like this, and I see them embedded in community. I'm a Navy brat, so we up and moved, and we became part of communities every 3 to 5 years growing up. So this notion of always picking up, moving, and then creating a new sense of community everywhere you went, and then sort of learning a new community and learning culture was all just sort of primed me for wanting to be working at a community level, but also understanding the nuance of culture and gender and all the different relationships and roles that people play. So I think that journey, even at U Maryland, it was one of the few PhD degree programs that allowed me the freedom to pick what I wanted across the university and build my designer PhD and do both the health behavior and health communication path. Most of the other programs I had applied to wanted me to retake my MPH again, and we've been working in the field for 6 or 7 years. I'm like, I don't need to take my master's degree all over. I want to go to PhD and take what I want to take and learn what I want to learn. So U Maryland was one of the few programs that allowed me to do that. So I got to pick and choose courses from across all the colleges at the university and build a degree that has served me well at CDC because I've served in communication roles and lead behavioral science roles at CDC, depending where I am in the organization. But it has certainly made me sort of a hybrid, mutt, whatever you want to call it, but versatile, so that has positioned me well to be deployed. A number of instances where they're trying to understand behavior, and then how does that turn into communication strategies. So it's served me well in that regard.
Great. Well, I think you're beginning to get a sense of Chris's love of learning and curiosity and why she's so valuable to CDC. So let me turn to you all and see if you have any comments or questions for her at this point. Dr. Lucian.
You had sort of early on when you were discussing things about, the concept of doing it right. Having been involved from both the epidemiologist perspective as an EIS officer, where health communication, not so much health.
Where lots of bad habits.
Where lots of bad habits created. I remember in particular, they showed us this whole video of how to do it wrong. Right? So 2 points of the question is, how much do you learn from things that didn't go right at the CDC, i.e. the disasters? And then at the same time is, how has doing it right evolved over the years?
The first one, CDC does, especially for emergency response and outbreak response, we do have a systematic process of after action report and reflection. And it's pretty systematic. What I'd say is the flaw in all of that is we don't actually take the lessons learned and apply them the next time around, because there's usually a new batch of people involved. As you know, CDC is a very decentralized organization with 11 different centers and institutes and offices, and depending on who leads the response, they are either part of the previous response and building on the learnings, or they're not. They're starting de novo with a blank page. So as much as we have a great way of documenting processes of emergency and outbreak response, we even struggle implementing what we know. I mean, I've been working Zika for the last 18 months, and it's probably been the most difficult assignment I've ever had in my life in terms of understanding the intersection of politics, economics, culture, poverty. I mean, it's messy. And the way epidemiologists, many of them are trained like nice, neat things, nice, neat answers. And a case, you know, some of the ways that we approach even articulating and describing public health problems can't be done just with a survey or a quantitative approach. It needs to be mixed method approaches and qualitative, and people are impatient with a qualitative, even though it can be done quickly. I proved it this last year, to inform insights and processes. So we are good at documenting. We're not good at always applying what we've learned. The second part of the question...
It's really evolution of how to do it right over the years. I mean, is doing it right in 2017 equal to doing it right in 2007?
Yeah. Well, and I don't know that we share a common definition of what right is. I mean, CDC might have a notion of what right means. A local health department may have a different definition of what right means for their community. Because as you know, public health is a local jurisdictional driven answer and solution. I mean, last year I think we saw a perfect example of how local jurisdictions in Puerto Rico had a sense of how they wanted to handle Zika and how CDC wanted them to handle Zika. And there was just a lot of fallout and different people's notions of what is the right answer to solutions. And the reality is it's complex. It usually takes time to sort all that out, and in outbreak and emergency response, time is the commodity we don't have a lot of because we're trying to make the best decisions at the best time, at the fastest pace to protect the most people. And so it's a convergence of messiness and a lot of stressors and a lot of real commitment to the need to listen. And that is one of my main challenges with my own network of colleagues at CDC across all the disciplines is once you get CDC, you sort of feel empowered to always be the expert and the talker. And there's something that goes wrong when we're always the talker and we stop listening. And my main goal at CDC, she can tell you, is stop talking and let's listen. We need to learn before we inform our own strategy. We need to learn from the communities that we serve to see what's going to work, what's not going to work. And that's still the challenge in every response is how do we build in infrastructure for listening and sharing those communications at a variety of levels of decision makers in the process.
Over here.
So it sounds like you have a lot of global initiatives just in terms of prevention and the health literacy. I'm curious how you and the CDC in general kind of surpass these language and cultural, and especially now, these contemporary political barriers.
Yeah, CDC actually has more of a workforce out. We're setting up country offices. So there's a workforce that's not just in Atlanta. We have a lot of people in different parts of the world. More and more of those offices are hiring communication professionals in country who understand the culture, understand the language, because there's no way you can just deploy me. And even though I've been deployed many times, the first thing I do is hire a translator and hire somebody local to be my shadow the whole time. And that's not something a lot of times the government will pay for. So a number of deployments, I've taken my per diem and purchased a translator with those resources because I don't think I can be effective unless I have somebody who understands the culture, understands the social norms, understands the language. But on the good news is there is a growing capacity overseas, and CDC is building its infrastructure and communication overseas as well.
I have just a quick follow-up question, just in terms of like countries that are kind of combative to the United States in that sense. Does the CDC still try to initiate preventative health literacy in those countries that are like kind of like we don't want anything to do with you, or how do we retaliate or respond to that?
Yeah. CDC is only where we're invited. Just like in states here, we can't just go and say, hey, we're coming to your country and we're taking over, or public health is jurisdictional. The local folks call the shots. I mean, I don't go to Puerto Rico unless Puerto Rico invites me. I don't go to Indonesia unless Indonesia makes a request for assistance. And that's true for anyone in the HHS family. We go when we're invited.
Thank you.
Mm-hmm. Any other comments? Okay, go ahead.
So it seemed like you had a really strong passion for your work in Maine. After your PhD, how did you decide to go to a federal level instead of back to the local level?
Oh, I had a moment of craziness. I love community level.
I'm so glad you did.
Well, the summer of the Olympics, which was 1996 in Atlanta, I did an internship at CDC. And it's really quite funny because when I left Maine to come here, Jane Root and Sue Plimpton sort of prophesied over it. You're going to go to CDC and make things better. I'm like, oh no, there's no way I'm going to CDC. Because I'd interacted with CDC as a grantee, and I'm like, oh, they're just a bunch of bureaucrats there. There's no way I'm going to go there. But I went there during the summer of the Olympics, mostly for the Olympics, but to do an internship while I was there. And met a group of people that were standing up in the Office of Communication. CDC had gone through a real thoughtful process where they realized that the only types of communication they were doing at the time were scientific publication communication and public relations, so news media. That was their communication portfolio. And this was at a time where the internet was emerging. This is pre-social media, so no Facebook, Twitter, or anything like that. But there was this real, Dr. Roper acknowledged that there seems to be this science of communication and health communication that CDC needs more of. This is in the area of HIV/AIDS emerging and all that stuff. And so he had led a team that reorganized how CDC and rethought how CDC was doing. So there was in the office of the director, there was an Office of Communication created that had a media relations side, public relations side, and this new Office of Health Communication. And it was that group of people who said, during this internship, they brought me in to sort of think through typologies of health communication and health behavior and what they needed to do and what kinds of trainings they would need to do to turn all their writer editors into health communication specialists. And that experience sort of teased me into coming because I thought, oh my God, they really need me. And my perspective, because I'm coming from a local level and many of them have never worked at a local level, so I wanted to be the voice of local public health at CDC. But I also had this unique training of health behavior and health communication from here that most of the people in health communication at CDC didn't have the pleasure of having. So I felt like I had something to offer them. So I spent my first few years as an internal consultant to CDC programs around health communication planning and evaluation. We developed this tool called CD Synergy, which is a CD-ROM tool that walks you through the process of doing health communication planning in a sort of science-based agency. And then I built pretty much all their courses that are still being offered at CDC University on audience segmentation, audience profiling, health behavior, theory 101, all that stuff that is still being used there. So it was too good to pass up. And then I got hooked on the science, and I never imagined staying in a federal agency for 20 years because I have this much tolerance for bureaucracy. Cynthia can attest to that. But the work there has been so compelling and so interesting. And I mean, the best part of working there is making friends and moving an agenda forward over time. Now we have a long way to go. So you have the half glass full, half glass empty days. Which one is it? You flip a coin. But at the same time, I've never been bored at CDC. I always have this much work to do and so many opportunities to sort of bring creative ideas and my passion to it. So that's why I've stayed there that long. I do get my community level stuff through my philanthropic work at home, so there's the bureaucracy, but then there's yes, I definitely need to be out in community, interacting with community and problem solving. So I definitely have that side of myself as well.
And we might add, too, that actually a faculty member from here went to be the first director of that office, Dr. Vicki Frymuth. So UMD also has that connection to CDC.
I actually nudged her to apply for that job. So, because I said, you have to lead this office.
And then, interestingly, CDC followed it up when Julie Gerberding was the director of the agency. Then again, sort of this rethinking, this is post-September 11th, post-anthrax, rethinking how communication should function, and that's when they created the National Center for Health Marketing. And that, again, probably just sounds bureaucratic to you, but you know, that was, again, a huge milestone, because what it said was that communication as a topic belonged at the same level as all these other topics. So you can imagine having a center on communication at the same level as these old guard infectious disease centers. That was like, you might as well have said there was an earthquake in Atlanta, right? So
Yes, there was.
There was.
And that's when you were recruited to CDC.
Yes, that's how I got there. I said, if an agency is smart enough to create a national center on communication, I ought to go and check it out. So, okay. I want to make sure we talk about our favorite topic, and probably the thing that will link us to our deaths, right? The CDC Clear Communication Index. So just a little background on that. Chris and I both had different roles on the pandemic influenza response, the H1N1. And we had a hallway conversation after that. And we said, you know, it was great that our colleagues, because we're at different levels of the agency, we said it was great that our colleagues were committed to plain language communication for pandemic influenza response. How did we do? Has anybody been looking at how we did in terms of executing on the plain language? We should check that out, right?
Well, and we were also pulling our hair out going, saying, did they just really say that?
Yes, we did.
Let's
yes.
be honest.
We did.
We're like, we said that? That was what went out the door? I can't believe it.
Yeah. So my role was always the money person. I went out and found some money for us to do a project. And we said what we were going to do was look at what CDC said about H1N1. We were going to look at what the media picked up. And then we were going to take those two things to members of the public and see what they thought about what we had said and about what the media had said. And unfortunately, I mean, not to our great surprise, but to a little bit of our dismay, we found out that there was a lot that people still did not understand. And we said, you know, we, the collective we there, not just Chris and I, but the collective we had made this commitment to try and communicate as clearly as we could about H1N1, and some things still didn't go right. So we need to figure this out.
This is about 10 years after lots of health literacy training at the agency.
Yes.
Sue Stableford had come, Jane Root they had come and really done a lot of influencing. So we had a lot of people trained in how to communicate in plain language and
Yes.
clear communication.
Yes.
But when we talked to our colleagues to say what happened is all that clear communication got undone by our clearance process, which is the review process that leaders do, and all the technical language and jargon got added back to it. So what started as clear plain language messages for the public ended up in scientific gobbledygook that nobody could understand. We said, how are you going to fix this?
And I forgot about the role of Simply Put, too, a manual that Chris helped initiate there out of the Office of Communication. We even had a manual called Simply Put, and it had Appendix A, which was the thing I went around, because I was in the Office of the Director of Communication, and I went around and asked everyone, so are you using Appendix A? Well, it was our checklist, our agency checklist, and everybody's like, Appendix A? What is Appendix A? I was like, oh, this isn't good. Nobody knows what the checklist is. So we said, obviously this tool, this, as the training people like to call it, this job aid, wasn't doing its job. And Chris and I said,
because people weren't hearing about it. There wasn't
Yes.
a systematic way
Yeah.
to make sure that people were exposed to it,
Yes.
embracing it, and then using it.
Yeah. So Chris and I said we have to tackle this problem, and that's how the CDC Clear Communication Index was born, and also trying to rethink the science, as you've heard Chris talk about. I mean, rooting all of the work that we do in communication science, we think is really a big part of the contribution that we've tried to make, is to say this is just not, it's not opinion, it's not just how somebody feels that day. There's kind of rules and principles that have developed over time using scientific methods, and we want to make sure that communication science is on the same footing as other science within public health. And so we created
There's
this
a
tool.
power dynamic that we deal with.
Yes.
In any organization, there's people high on the totem pole and there's people lower on the totem pole. And communication folks tend to be lower on the totem pole, even though they are incredibly influential, important to every organization in terms of communicating its mission and accomplishing its mission. So Clear Communication Index was a way to say, equip the communicators with the science behind what they do and why they do it, so that when they're interacting with the scientific experts around their science and communicating their science, it's not my opinion versus your opinion. It's the science says we need to go in this direction. And a core value of most folks at CDC is around science. So you can either say, okay, this is our core value, or we're going to be true to it, or we're going to call it out when we're being hypocrites.
Yeah. As you can tell, Chris doesn't pull any punches.
I don't. I'm a damn Yankee thriving in the South.
So if you could talk a little bit then about what effect you think we've had with the index. You know, we released it about 4.5 years ago now. It was in 2013. And so now from where you sit in your roles, can you talk a little bit, can you give a couple of examples of how you think things have changed as a result of doing the index and you know, all the effort we put into training people and doing that promotion that maybe didn't happen with some of the other tools?
Yeah. Well, this goes back to the notion that CDC is very decentralized. Each center sort of decides how it's going to either apply recommendations. CDC Clear Communication Index was not a requirement from the Office of Communication. We really wanted them to say, hey, we're a science-based agency, here's some communication science, we should be doing it this way, and it's our dream to someday see a MMWR saying reports and recommendations around Clear Communication Index. But it was recommended, and each of the communication directors at all the different centers either said, yes, I'm going to use it and build a system, and there were a few. The National Center on Birth Defects and Developmental Disabilities embraced the index and built it into their organizational culture and their processes and built lots of supports for it. So when you look at the stuff from CDC's National Center on Birth Defects and Developmental Disability, you see plain language, you see audience perspective built into it. Unfortunately, my center is not one of those centers.
But some of your divisions.
Some of my divisions,
Yes.
the Travelers Health website, if you travel, and the people who do refugee health, they really embraced the index in a really nice way. So we have pockets, probably the foodborne in some areas, and waterborne disease prevention group
People still
embrace.
don't believe that the agency has a poop in the pool campaign.
I know, that was a big
Big
thing.
deal. People are like, CDC can't say poop.
And we're like, yes, they can.
Yep. Yeah, that was a big victory for my center,
Yeah.
getting that through clearance.
Yeah.
Saying, yes, that's what audiences say.
Yeah.
So we have, you know, like any organizational change process, 4 years is still very much at the beginning. As much as I'd like to say it changed the world and we're all good, you can look at our Zika messaging in the last year and see that we're not incorporating plain language in all what we're doing. When we have a million different fact sheets and a million different messages, and it's messy. So I have a vision of students using a Clear Communication Index on all the materials and sending feedback to CDC info saying you're failing on your own index. I told her, I said, we need a workforce outside of CDC calling us on it.
So I'm going to put on a trench coat and dark glasses and a hat. I'm going to sneak around and we're going to do that. Yeah.
So yeah, we still have a long way to go. But again, CDC is not a static environment either. Every year we have a new batch of EIS officers, we have a new batch of fellows, we have a new batch of new employees who all, again, have to learn the way CDC does things. So the training has to be maintained. It still needs to be integrated in what we do and how we do it. And building a health literate organization will take time. So we're still working on it.
So comment, yeah, we have a question or comment there in the back.
So is the training available as part of your onboarding, especially because you have such a dynamic workforce that comes in and out?
I would like to say it is, but it's catch as catch can. For a number of reasons. One, she left. You have her now. Though there's a couple people who are holding the fort for her. We are working to incorporate into some of the fellowship program, the trainings of fellowship programs, because that is a sort of systematic onboarding process. Believe it or not, for communication professionals, there's, other than the CDC orientation where you sign up for your health benefits and your insurance, there isn't a systematic way of training them even on how to do communication at CDC. And that's one thing I've been talking with the director of the Office of Communication there is like, I want to lead a boot camp for new communication employees and show them, you know, the IRB, the OMB, the permissions processes, all the different, there's lots of permission seeking processes when you want to talk with more than 9 people in America about something. And they're just the bureaucratic processes you have to navigate. So don't avoid them, just learn how to do it and do it so you can do your job effectively. And so I've been pitching the idea of a boot camp for communication professionals coming into the CDC so they'd learn how to do things the right way instead of keep any bad habits. But again, I'm expecting trained University of Maryland graduates to come with clear communication index experience.
Yes, yeah. So there is a part of what we've been talking about, though, that is required. There's a federal law called the Plain Writing Act, and that requires all federal executive branch agencies to use plain language. And so what would happen as part of the onboarding process is that we would delegate to these national centers that Chris has been talking about. They were the ones that had to certify that they either confirmed that the incoming staff had plain language skills or that they would get training within the first 30 days to have those plain language skills. So,
Great.
Any other comments or questions before? Go ahead.
Question just about how you deal with cultural differences and how you work with staff to incorporate that into the materials. You talked about it with Zika being a challenge in Puerto Rico, and because we do have students who try to create materials for different cultures. Yeah, what do you recommend?
Yeah, my recommendation is to start with audience research or co-opting and co-creating. I mean, that's the ideal process. Unfortunately, in most federal agencies or even state and locals, we always start with our first draft and then maybe pre-test it with an audience, which is not ideal. I mean, the reality is we've got to learn from our audiences first and shape the communications with their input along with subject matter expert input in terms of what needs to be accomplished. That's when things happen well. But unfortunately, we still start with science-driven communications where a SME or a subject matter expert wants to say something. Again, that's that imbalance between telling and listening. And I really feel like we need to listen first and listen a lot and listen often in order to get the best communication. So, I mean, I know that when I'm deployed in emergencies, hiring a translator, spending lots of time with people, listening, that's my preferred thing. Talking is actually, I'd much rather listen than talk any day. But that's the ideal way. And a lot of people use bureaucratic processes as obstacles, but I don't, having worked Zika and done 7 OMB packages and these permission-seeking processes in the last year and done this quickly, I'm no longer accepting it as an excuse. It can be done. We just have to have the will and the commitment to do it.
So you've referred to your experience with Zika being the most challenging or complex response that you've been part of. Are there any other highlights of your career, either in terms of things that worked really well that you feel very proud of, or things where you thought, wow, this didn't go quite as well, but I really learned a lot? Any other highlights you want to share?
I think one of my favorite experiences was being deployed to Indonesia in 2005, just as Hurricane Katrina was landing in New Orleans. I'm flying to Indonesia. And they had been polio-free for a decade, and their immunization coverage rates had gone down, and a traveler went to the Mecca, to the Hajj, and came back infected, and started an outbreak of polio in that country. And they had rallied to have get immunization polio to kids in these 3 provinces to sort of stop the outbreak really quickly, and they rallied really well. But after that first immunization event, there were these news reports of vaccine-derived polio. So people became afraid of the vaccine. And they had another immunization event where hardly anybody showed up. Like 1 million fewer kids showed up than needed to be immunized. So they called CDC and said, help! And I was the lucky one who got to go and do the behavioral sciences, the field research, the figuring out on the ground with my translator, and developed 2 back-to-back communication campaigns based on theory, health belief model, first one, social cognitive theory, the second one, and really do it out in the field with, collaborate, do it the right way with all the audience research, all the engagement, without the CDC bureaucracy, because I would never have been able to do that in 90 days that quickly, and to see the outbreak stop. So it was very tangible, very concrete, rewarding experience of how can you turn something that started out really well, went south very quickly, bring it back so that parents, and we actually did wonderful radio shows that had the key characters that were addressing the issues, the parent, a local government leader, and a healthcare provider having demonstrating the conversations that were answering the questions that people had. And that storytelling format was a very cultural approach to that solution instead of just throwing out a PSA or some other format.
Yeah, go ahead, Liz.
I just wanted to ask if there's any publication on that, or something that would be a great case study for our students.
Unfortunately, publishing has not been at the top of my list. I do regret that I haven't made that a priority over my career.
We'll just have to bring you.
Yeah, it's all here.
Yeah.
I actually read my trip report on the plane here. I'm like, oh my God, I can't believe I did all this in 90 days. But it's like, oh wow, that was really cool. So yeah, and that is the fun part. Early in your careers, just say yes to everything. Don't be picky. Every experience, you will learn what you're good at, what you're not good at, what you like, what you don't like. And I see young professionals, because we're right down the street from Emory, coming in saying, I think I want to do this. And when you give them an opportunity, would you like to try this? Oh no, I want to do this. And like, oh, come on, you're short-circuiting your learning here. So don't get fixed too early. Be open to having different types of experiences that can shape you, as well as meet people who you might want to work with. So that open the door. Don't close the doors before they open.
Exactly. Kathy, you had your hand up.
I just wanted, that you just mentioned that, I did go to Emory and I did do an internship at CDC in the summer of 1996.
Great.
And I was in the health communications branch of the Office on Smoking and Health. Mm-hmm. And it was slow because everybody left because it was the Olympics and we were working on the Surgeon General's report for physical activity, so a bunch of people got sent there. And they asked me, would you like to go over and work in the policy division? We want to write up the Massachusetts and California, Medicare suits and all that kind of stuff. That was when Kessler was testifying and all that kind of stuff. Anyways, long story short, I said yes. And I went over to policy and then EPI, and it was great. Anyways, so my question is, and I can probably just say 2 words, back to H1N1. Joe Biden on the Today Show. What was the reaction from your office?
I can't remember the event, honestly.
2009,
I'm old.
2009, Matt Lauer asked Joe Biden, is it safe for the American public to get on an airplane? And he said, I would not get my family on an airplane with H1N1 circulating. And that came from the White House. And I was just wondering what did the Office of Communication at CDC, who supposedly was supposed to be getting everybody on the same page, remember that?
Operational worders are supposedly, because I've worked in a number of outbreak, and even I'm not in the Office of Communication now. I do not know what the Office of Communication thought about it. I can imagine that they were like going, oh my God, did he just say that? That's what I can imagine them saying. So I can imagine that. I was working anthrax when Tommy Thompson was secretary and saying all sorts of funky things. I was working the foodborne outbreak with the Salmonella typhimurium peanut butter thing, where we had senators holding up jars of Peter Pan or Jif and all that stuff on the Congress floor, and it wasn't those products that were involved. I'm like, oh, come on, guys. So we don't control everything. We can say, here's what we know, here's what we don't know, here's what we're trying to learn, and do that as well as we want. But then people do take it in their own ways. And now with millions of channels and Twitter and Facebook, it can go in really funky ways very fast. So it means that we need to be more intentional in communication and relational in our partnerships, both with media but also partners, so they're not blindsided or advancing odd ideas about things. So I mean, we really have to be thoughtful in what we do. And I do think, I mean, a lot of people think policy is separate from communications. There's policy communications, there's policy, there's communications for behavior change. There's lots of different specialties in communication now. And you have to know each of those audiences really well to be effective in influencing them.
And I think the other thing just to remember is, CDC is an agency within the Department of Health and Human Services, and the Department of Health and Human Services then basically reports to the White House. And so, the alignment of any message is always a challenge, whether it's a response or non-response, right?
And each administration has its own level of ways of either aligning or not aligning.
Yep, exactly. Bob, you had a question?
Yeah, in fact, related explicitly to this with politics. If politics trumps science, politics trumps everything. And I didn't mean to use that word. It was Tommy Thompson who told Vicki Frymuth that she had to clear everything she said through his office, rather than the other way around. And that was very unusual.
He was. Well, and he's not the only leader from high above who's told CDC what we will and will not communicate.
So, all right, Ken.
Christine, do you have a sense over the next 10 years, say, of what the issues are likely to be? And what advice would you give a school of public health to prepare our students to be players of major issues that you see coming down the pike in the next decade or so?
Well, I think emerging diseases will be from my center's perspective. Well, certainly most emerging diseases are zoonotic in nature. So this notion of the interaction between people, animals, and environment in the era of change in weather, change in climate, I think that space for disease transmission or disease emergence is going to is accelerating. I mean, just look at Zika, how it made its way around very quickly in the grand scheme of things. And I think most local public health departments haven't thought about their physical, geographic, ecological space as it relates to public health. I mean, I think the chronic disease side of the world has done really well in terms of thinking about structure and infrastructure and sidewalks and getting grocery stores in different places. I don't think we've had those same conversations around infectious diseases when it comes to mosquito control or rabid animals or even deer control, dealing with deer and Lyme disease up in New England. So I think the public health, my perspective is the public health community needs to do more on sort of the environmental health interface and the infectious disease interface, and even the intersection with chronic disease. I mean, CDC is so siloed out of necessity because of budget lines and how budgets are built. But the reality is most infectious diseases set you up for chronic diseases, and most chronic diseases set you up for infectious diseases, and we're not having conversations across. I mean, who knew that a salmonella infection could make you arthritic for the rest of your life? I mean, those connections exist, but we don't have interventions or conversations or engaged communities in ways that can address those real issues. So I think seeing more connectedness or having practitioners who can connect the dots and not be so specialist in terms of, I only do cancer prevention and control, or I only do this. I think we need more generalists who can then go deep on a variety of topics and connect those. But I also think we need professionals who can connect different disciplines and connect different parts of the community to have those conversations in productive ways. And I know, I mean, when I started many moons ago, community engagement and community mobilization was a big part of my master's degree program at UMass Amherst, which is why landing in the local health department sort of suited me. But the way I see most local health departments now, I don't see the same level of engagement of community or the connecting of partners. I see coalitions, but I don't know that I see the same level of partnerships and commitment to defining, characterizing problems, and then co-creating solutions to those problems that are literally locally and community-based. I get concerned at local investments in public health infrastructure. I mean, I get concerned at how much how much the country's infectious disease infrastructure is funded by CDC. And what that goes away, it means that then the capacity goes away at the local level. And the reality is infectious diseases have they have a place component. So we need local communities to know that their topography, how they design their communities, how they interact with animals in the environment in their community are just as important as whether they have a grocery store with healthy fruits and vegetables in it. So I think expanding sort of the ecologic approach to public health. I mean, we say it, but I don't know that we really do it. That's my thought.
Okay.
You can disagree all you want. I'm not see it happening.
Well, we've come to the end of our time, and I'm going to end with a self-interested question. So what would you like to see the Horowitz Center for Health Literacy contribute to public health based on this description that you've given us all here?
I have a long list here, but
Okay, all right, well, you can give it to me after.
Okay. Well, I think you're here at the University of Maryland. If you're in a unique position to make every graduate of the University of Maryland an excellent ambassador for health literacy, not just from I know health literacy, but I can do it well, both in terms of engaging communities and building capacity for whatever products and services that you're going to develop, but also influencing the organizations that you're going to be a part of. So equip them to be awesome, competent, proficient health literacy practitioners, but then also equip them to be change agents in whatever organization they're going to land, whether it's a local health department, state health department, NGO, or CDC, because I want to retire in 10 years and I need folks to step in.
Great. Well, join me in thanking Dr. Christine Prue. So now I would like to invite to the podium Dr. Rima Rudd from the Harvard School of Public Health. So Rima has a list of accomplishments in health literacy that go on and on and on and would take up the rest of our time here. But I just want to point out a couple of things. That Rima really has helped define and lead the space around health literacy and public health. She taught the first health literacy courses within a School of Public Health context, and she continues to contribute in multiple ways, and she told me to be sure to mention that she's still teaching. In fact, I was up at her class last week, and I can attest to that. So Dr. Rudd was present, as we said, at the founding of the Horowitz Center, and the other thing that apart from her superlative contributions, the other reason that we really value having Dr. Rudd here today is that we're relaunching the Rudd Graduate Fellowship that the center has. So a number of years ago, this fellowship was established to help support graduate students during a year of writing their dissertation. And so we're happy to announce that we now have 2 years of funding for that. So we hope to select 2 graduate students to support in the coming years, and we just wanted Dr. Rudd to be here and thank her for her contributions to the field, and we're very happy to have a named fellowship for you. So Dr. Rudd's going to just make a few remarks now.
Great. I will make sure that I'm never on the agenda after Chris Prue. My very brief remarks would always precede, because it's a very hard thing to follow, the passion and the excitement and the wonderful accomplishments. It was really a delight. I was very much honored to be here at the launch of the School of Public Health, to be here at the announcement and launch of the Horowitz Center for Health Literacy, and further honored to have a fellowship noted in my name. And it's a great pleasure. And I was asked simply to say a few things very briefly in regard to that, mostly to encourage you to really focus attention on health literacy and value the importance of health literacy, whether it's something that's going to be the totality of your research work or the totality of your practice work, to come to recognize that health literacy offers not just a new variable in health research, but also insight into any aspect of public health work, whether it be in practice, whether it be in research, whether it be in teaching, or whether it be in policy. It's a very important added ingredient. And for this, I'm going to, although I'm going to mix metaphors all over the place, I just want to come to a metaphor that was used by Richard Carmona, who was then the Surgeon General in the United States in 2004. And I took my phone up here to make sure that I used his words. Health literacy is the currency of success for improving emergency preparedness, eliminating health disparities, and preventing disease. I like that notion of the currency of success. Health literacy is not asserting itself as a new discipline. It's not asserting itself as a total field of study in and of itself, but instead as an aid, as an assistant, as insight that can be brought to all of our studies in public health. The scientists being able to communicate with the practitioner, the clinician being able to communicate with the patient is a very core feature of what's going on. But society's role in fostering knowledge, new knowledge, both the creation of knowledge and the transmitting of knowledge, we can either open the door for someone to learn more about their own health, their family's well-being, issues in occupational health that might be confronting them, issues that are going to be confronting the community, or we can slam the door in people's face. And for too long, we've been locking that door. We've been holding off on people's access to information because of the way we've constructed information. Now, I'm not just talking about materials, things posted online or things written in books, but I'm also talking about the idea of how we talk to people, whether or not we engage in respectful dialogue. And it's not respectful dialogue when I start using the jargon of my trade in order to talk with you, because I'm holding you away. I'm pushing you away when I do that. So respectful dialogue. And it takes us into the realm of preparation, how we prepare our young professionals, whether it be in medical school or nursing school or schools of public health. It also has to do with our systems and how we construct our systems. Because when you talk about literacy and when you talk about health literacy, it's not just an interaction, although this is important, the interaction from the public health perspective over the airwaves of talking to the public, or the clinician's perspective of talking to individuals one at a time. But it's also how we educate our scientists, how we educate our professionals in communicating the important knowledge that they've helped develop. How do you transfer that information in a respectful, easy way, not talking down to people, but so that people can be on board with you, can understand what you're saying and why you're doing something in a particular way. And how we structure systems so that systems are easier to navigate. And I don't mean simply the hallways and byways, although they're important because they do set a mood and they set an atmosphere. But how you can navigate a system through its bureaucracy, through its forms, through the demands that they're making on someone, and that may eventually let people look for the exit again and just find their way out because it's too cumbersome, it's too demeaning, it's too insulting in some ways to make your way through that kind of system. So health literacy offers insight into how we can create systems that are friendlier, that are more welcoming to people, how we can create dialogue on multiple levels, whether it be the scientist to the health practitioner or whether it be the practitioner to the patient. And indeed, how we help create respectful and informed dialogue within communities. So there are lessons to be drawn, insights to be gained, and I think it helps no matter what field of study, no matter what area of expertise you really want to focus on. It's an assistant, it's an aid, it's a guide, and it can be profound. And I certainly hope that whoever's doing doctoral studies, who may be in this room, applies for funding. It would give me great pleasure, because then I'll have the delight of interacting with you, because that's kind of built in a little bit. And there's so much to be gained in asking questions and formulating wonderful research questions that can take you down the route of either individual change or practice change or professional change or policy change. It's a really wide open field that includes numeracy, that includes words, that includes forms, that includes looking at language, that includes communicating over the airways. And health literacy can be an area of enrichment along those lines. So this is a unique school of public health. It is a powerful school of public health, and in part because at its core, it also has, it's the only one, it also has this notion that health literacy is a core foundational concept and talent and skill, and I really celebrate that along with you. So thank you for inviting me back for that.
So Dr. Prue has to return to Atlanta tonight, but if you want a little more chance to interact with Dr. Rudd, she's going to be giving a guest lecture in my health literacy graduate class tomorrow night from 4 to 5. We're downstairs in the Behavioral and Community Health conference room, and we do have a few seats that we can squeeze you in if you'd like to come hear a little bit more from Dr. Rudd tomorrow night. So I want to give Dean Lushniak the last word if he would like it.
Great. This has been really quite the impressive afternoon, hasn't it? And a round of applause to the organizers. A round of applause to our speakers and to the faculty that have come from afar to share their insight with us, Dr. Prue, Dr. Rudd. And then a round of applause for everything that we stand for in this room. Right? Whether you're a student here, whether you're a faculty member, whether you're a staff member, whether you're a visitor, right? What binds us together in this room at this point in time is the important mission of public health. And a key component of that mission is what we had discussed today, was how do we get the information out? How do we get it out so people understand it? How do we make this as important as the other facets of public health? That's what we've been trying to achieve here with the Horowitz Center for the last 10 years. And as the current dean, I take upon the mantle both from Dr. Gold and Dr. Jane Clark to continue the work for the good of this bigger public health mission. So I think now is going to be time for celebration.
I think so, but I'm not entirely sure where we're going.
Okay. Nor do I.
Oh, right out
Somewhere
here.
out there.
Okay, right out here. So please join us for a reception.
In closing, I also want to compliment Cynthia Baur for a job well done here as the center director. We talk about the interplay between the School of Public Health and its centers. The center, as you've heard already, is a key component of this. Also, Cynthia and I are bound together in that we walked in through the doors as new members of this family at the School of Public Health on the very same day. I also have the connectivity because I spent 16 years of my career at the CDC and have my master's in public health from Harvard University, so there's that connectivity. So you never know how you're going to connect with people. During our reception, meet someone. Begin those connections right now. Thank you so much.